Good morning, everyone, and welcome to our first Endo Expert Hub monthly case discussion series. My name is Zehra Tekin. I am an assistant professor of endocrinology at UT Southwestern, and today we'll be focusing on primary aldosteronism through real clinical cases, with an emphasis on practical decision making, I think, because we have very limited time in the clinic, and we get and we're hoping to get more and more of these referrals, right, Dr. Hamidi? So hopefully, we're really excited to be joined by Dr. Oksana Hamidi, who will be walking us through these cases with her expertise. Oksana, thank you again for being here.
Absolutely. Thanks for having me.
All right. Now, I want to briefly introduce you, Dr. Hamidi, to our audience. Dr. Oksana Hamidi is an associate professor of endocrinology at UT Southwestern, with expertise in complex adrenal cases. I'm really lucky to work alongside her. She's incredibly approachable and resourceful, and I really often rely on her insights when I'm treating my complex adrenal patients. Again, that's it's great having you both here and at my workplace. And going on our disclosures, I have nothing to disclose, and Dr. Hamidi serves as a consultant and advisor to several companies and has been involved in clinical research trials as listed here. Um, so we'll go ahead and move on the objectives of this presentation, this session. By the end of this session, we hope that we recognize now the spectrum of, actually broad spectrum of primary aldosteronism. And we should be able to apply updated screening and diagnostic strategies, including ABS, into our clinical practice. We will also hope to review current and emerging, treatment options with Dr. Hamidi. And we'll do that through interactive cases. So let's jump right into our first case. We have Dr. Hamidi, a 45-year-old woman with long-standing hypertension. She's on chlorthalidone, losartan, and hydralazine with appropriate control. And she had a screening for primary aldosteronism done, which showed aldo concentration of 21 nanogram per deciliter. Plasma renin activity was suppressed with a serum potassium of 3.4. So our next question is it reasonable to continue with her current treatment since her blood pressure is well controlled on triple treat therapy?
First of all, thanks again for having me here. I'm really excited to share these cases, and we picked out cases that are actually from our clinics and make them realistic. And I would like to add here that before I answer the question, is it reasonable to continue her current regimen since her blood pressure is under control? Firstly, it's very important to acknowledge that she got tested for primary aldosteronism, which is a big bottleneck for most of our cases. So just wanted to acknowledge that this was absolutely necessary. And as noted here, her workup is really diagnostic of primary aldosteronism. So we are really not questioning the underlying etiology of her hypertension here. Now, to answer the question, is this reasonable to continue her current regimen? And you see she's not on any mineralocorticoid receptor antagonist. That's where the question is coming from. And my answer is no. Patients who have confirmed primary aldosteronism, or PA for short, and let's add, if she's not a candidate for surgery, she she should be treated with mineralocorticoid receptor antagonists such as spironolactone or eplerenone, and that's regardless of her blood pressure control status. And later in this presentation, we'll talk about also how to target as mineralocorticoid receptors when we are applying medical management for PA. And the reason why it's not appropriate to continue her current regimen is because risk of cardiovascular events and organ damage is disproportionately increased in patients with primary aldosteronism, even when they're matched for blood pressure control to patients who say have essential hypertension but without the underlying PA. And this is the data. Ultimately, I know the font is small, but ultimately I wanted to highlight the main findings of this meta-analysis. So looking at target organ damage in primary aldosteronism cases compared to essential hypertension matched by blood pressure, you can see that there's a substantial increased risk in stroke, odds ratio of 2.6, but also in atrial fibrillation, odds ratio of 3.5, coronary artery disease, odds ratio 1.8, and heart failure, odds ratio of 2.0. So given this data, I would say that this is an absolute no. We should definitely tailor her treatment to treat her for the underlying PA as opposed to just using her antihypertensives.
So this study was done on patients who have normal blood pressure, right? Like
So this is actually
controlled blood
patients
pressure.
who had underlying essential hypertension.
Mm-hmm.
And when we are matching them by blood pressure control, patients who have
Exactly.
underlying PA but not treated accordingly have significant risks for these cardiovascular
Yeah,
issues,
such an important point that, blood pressure control alone doesn't eliminate the risk of cardiovascular disease. So,
unless we treat it appropriately. Absolutely, that risk persists. And I just wanted to highlight two findings from the 2016 guidelines and then also more recent guidelines that were released last year. So basically, this is a laundry list of reasons to test for PA based on 2016 guidelines. And I'm not going to read through it because technically I don't want to commit this to my memory or anyone else's memory, since this looks really complicated. And probably that was the reason why we were not testing for PA. It was just a long list and hard to remember. And these are the recent guidelines from last year, 2025. And these guidelines are also consistent between Endocrine Society, European Society, but also Japan Endocrine Society, ultimately saying that in all individuals with hypertension, we suggest screening for primary aldosteronism. So basically, it's an individual with hypertension, and technically, we are saying that at least once test this person for PA, regardless of blood pressure, underlying medications, underlying comorbidities. And the testing is much more simplified. Just basically, we are recommending to measure early morning aldosterone, renin, and potassium. And that should basically be the simple strategy, hopefully less resistance compared to 2016 guidelines. And to note, primary aldosteronism underlies about 15% of all cases of hypertension. And when we are looking at subgroup of patients with resistant hypertension, accounts for at least a quarter of all those cases. So this is a very prevalent disease and absolutely needs to be tested for so that we can manage these patients appropriately.
so Dr. Hamida, I have a quick question here. I feel like because primary aldosteronism is vastly untreated, underdiagnosed disease, to me, even the previous list, like we weren't following, the rates of screenings were so low. So to me, like screening all the individuals with hypertension seems very unrealistic. So would you still, I feel like this is just to increase the emphasis on screening. I mean, what do you think? Do you still recommend people in like limited resource settings to risk stratify, maybe at least? How would
I
you
think
approach?
that this is absolutely a very important question to answer because, again, what are we trying to achieve with this?
Mhm.
Ultimately, with simple strategy of just measuring early morning aldo, renin, potassium, when there is a diagnosis of suspicious, the labs are suspicious for
Mhm.
diagnosis. Yes, in some centers, in some settings, it's very possible that we have all these resources to do adrenal vein sampling, send them for surgery, and we'll talk about that more a little bit later. But say if we are in a limited resource place, by knowing if the patient has a primary aldosteronism or not, we can simply treat them with spironolactone or eplerenone, which then does not really add to the burden of pills. If anything, then we are able to reverse all of those cardiovascular complications that are amplified without appropriate treatment and bring the patient back to their baseline cardiovascular risk.
Okay,
So
wonderful.
I would say loud, yes.
Wonderful.
It's
Yes.
important to test.
And especially considering that how simple it is now, to screen for. Yes.
And treat. Treatment is
True.
readily available and more treatments are coming, but current treatment is relatively cost effective,
Hmm.
available, and we're already using it for other causes of like heart failure, for example. Okay, so let's keep going just to highlight what the guidelines are saying. So say you have an individual with hypertension, we'll start there. The first step is to perform screening. And by that, we mean measuring aldosterone, renin, and potassium. And the guidelines, as you see, list different assays, but also different units. So say if we are measuring renin activity, it should be at least less or one or less than that. And aldosterone at the same blood draw is at least 10 or more, and the patient has a aldosterone to renin ratio, again, depending on which assays are available, either more than 20 or more than 15. But also we have those parameters in direct renin concentration, and as I mentioned, aldosterone in LCMS or immunoassay. So really depends on what's available in your local practice. And if those parameters are met, so again, aldosterone 10 or more, renin is 1 or less, and aldosterone to renin ratio is, say, at least 15 or 20, then ultimately, if it's on the yes side, which is on the left side, that's the next step is to really think about these tests and make sure we are not dealing with false positive results or also false negative results. So say if we are suspecting false positives, maybe there are some underlying beta blockers or centrally acting alpha 2 agonists like clonidine. These medications can lower renin, increase aldosterone to renin ratio. So say maybe we are suspecting false positive. That's when you can move on to step 3 and either adjust their medication by withdrawing the medications that could be causing false positives, like their beta blockers, if it's reasonable, and then retesting. But that's only when you are suspecting false positive results. That's when you would consider adjusting their medications. Otherwise, if you are not suspecting, then you're saying at this point, primary aldosteronism is likely, and this is when you would proceed to further steps. And then say if you did morning testing and it's not consistent with primary aldosteronism, but you still have a level of suspicion, clinical suspicion, then you want to see if your results are false negative. And if you suspect that something is not making sense, the patient kind of meets the phenotype, and you want to see if they have reasons for false negative results that would warrant retesting. So one of the common issues is hypokalemia. That's why we recommend checking potassium just to make sure it's not causing false negative results. If the patient has hypokalemia, you want to correct it and then retest. Say other medications, like the patient is already on mineralocorticoid receptor antagonists or amiloride or diuretics, and it's throwing off your aldosterone renin, then you can potentially adjust those medications and retest. But that said, if renin is low despite all these treatments, then you can go ahead and with confidence interpret your aldosterone, because ultimately that would mean that even in the setting of those medications, if renin is
Hmm.
suppressed, then whatever is aldosterone is made is by adrenal autonomy at that point.
Hmm.
So if everything is still, despite retesting, the labs are not consistent with primary aldosteronism, then you say primary aldosteronism is unlikely, and you will continue antihypertensive therapy per general guidelines for primary hypertension. But if you say corrected all these factors and now primary aldosteronism revealed itself, like I mentioned, correcting hypokalemia or sometimes withdrawing some medications, and then retesting, and that should help you finalize the diagnosis to kind of go back in retest mode and then determine if you are dealing with primary aldosteronism or not. But also, ultimately, what this shows, it's a busy figure, but it does give you guidance as far as which part of the workup you're on, but importantly, incorporating your clinical suspicion into this context. Okay,
All
so with that,
right.
let's move on to case two.
Yes, we have a 39-year-old man on three antihypertensive medications, and he had a positive biochemical screening for PA with aldosterone of 12 and express-renin and mildly low potassium, I mean, low normal potassium of 3.9. And abdominal CT showed 1.5 centimeter right adrenal adenoma. And previously we used to call this confirmatory testing, but patient had further testing for primary aldo with oral salt loading, which also showed aldosterone of 13.4, which is inappropriately elevated. Now, let's move on to our question. Since patient has one adenoma on the right side, would we need ABS? And given his age of 39.
So yes, we are looking at a couple of factors. Basically, the question is about adrenal vein sampling, when to do it, when we can skip it, when we go directly for surgery. So this is a 39-year-old man. So that's the age range when the prevalence of adrenal incidentalomas are about maybe 3 to 5%. So what that means is we might encounter adrenal incidentaloma that has nothing to do with his primary aldosteronism. So that's kind of one key concept. And then also, as you can see, his labs, whether we are using immunoassay or liquid chromatography, mass spectrometry assay, those labs are confirmatory of primary aldosteronism, and we would say that PA is very likely. I don't think we are questioning the diagnosis.
Mhm.
We decided to do aldosterone suppression test, mainly not to confirm the diagnosis, but to help us decide is this PA that is likely to lateralize.
Mhm.
And the idea is that if aldosterone is higher, aldosterone to renin concentration is higher, and also these suppression tests are positive, then there's a higher likelihood that this is a unilateral disease. And maybe in those cases, adrenal vein sampling is worthwhile because we can offer surgery that could be curative. Say if the levels are borderline, aldosterone is still in a range of PA, but kind of milder case, and these aldosterone suppression tests are mildly elevated, or sometimes they can come back normal, just they don't have great sensitivity, then we can say that most likely this is a bilateral PA case. So it does not
Mhm.
exclude PA, but it just kind of highlights that this is most likely a milder case, which tend to be bilateral. And maybe in that case, we would opt for medical therapy, and
Mhm.
then not initiate a complicated process of adrenal vein sampling. If you have to refer those patients elsewhere, sometimes they have to go out of state for this procedure. So that's what we think about when we are using this information, this biochemical data. So ultimately, I wanted to share information on prior literature that looked specifically at the correlation of CT findings and adrenal vein sampling. So all these patients had both. And what I can share with you, going back to 2001 all the way through 2017, including a meta-analysis in 2009, you can see that there were some studies had only say 38 subjects, but with meta-analysis we were able to capture up to 950 subjects. So what I can share with you in the rightmost column, you can see that the percent concordance between CT and ABS, meaning CT, like in our case, showed left adrenal nodule and ABS, I'm sorry, right adrenal nodule and ABS lateralized to the right. So that concordance rate is very low, anywhere from 32%, maybe at best 65%. And
Mm-hmm.
what it means is that basically you're flipping a coin. If you're just going by CT findings without AVS and sending that patient for surgery, you might as well flip a coin and go for that adrenal gland because the correlation is at best 65%. So with this information, adrenal vein sampling remains the gold standard to help distinguish unilateral from bilateral aldosterone production and also right versus left to help guide surgery. And across
So,
all
Dr.
these cohorts, the accuracy for CT to lateralize PA is typically 30 to 60%, rarely exceeding 65%.
We do have a question, Dr. Hamidi. Do you recommend washout periods enough in your practice?
Hardly. And that's because most patients who come in, they are on doses that are low enough to cause any interference. And what we routinely do before adrenal vein sampling and on the day we check potassium. Potassium must be normal before adrenal vein sampling to the point we have a pretty strict protocol to cancel adrenal vein sampling if the patient comes in for AVS and their potassium is low, below normal range. That's because it can cause false suppression of aldosterone and throw off the interpretation. And we do not want to repeat this whenever possible. Meaning we don't want to repeat the adrenal vein sampling because it was, potassium was 2.8, so we cancel that. So that's first thing. Also, so potassium must be normal on the day of AVS. So we are very careful with adjusting and checking it before the procedure. Then the second piece of this is renin. Renin is something we also check routinely, and I will actually show why, but ultimately renin must be one or less. And ideally, it should be completely suppressed, regardless of medication. So if the patient is on spironolactone, as long as their renin is suppressed, then I do not wash out any medications.
Mm-hmm. Um, Dr. Hamidi, we have more questions. Another question, how about age cutoff for ABS? I think for
Yeah,
patients
we
who
will
have,
go over that in the next slide, actually.
uh
So I will show that information and that should be available to you.
sure. And how well does the salt load correlate to unilateral or bilateral disease? Would you
I love
regardless
that
get
question,
a?
and we have no idea. More information is to come, and actually, one of the debates, I can't remember if we incorporated that or not, is basically to do soul loading tests or not. And with these 2025 guidelines, as you can tell, we are kind of staying away from saline suppression test or oral salt loading test because they just have a very suboptimal sensitivity and can cause false negative results, and we can miss the disease.
Mm-hmm. And even
But
the
yeah, we don't have good data.
utility of CT scan, because we will eventually need AVS anyways. I don't really see a point of getting a CAT scan here. What do you think,
We
Oksana?
do want to get a CAT scan. That's because we
For
just
the
want to make sure
AVS?
there we know the anatomy and
Yes.
just in super rare cases, if you have like adrenal cortical carcinoma causing this, again, exceedingly
Hmm.
rare, but we want the anatomy. That's the reason to get a CT scan in case there's, occasionally we catch one kidney or some
Hmm.
anomalous venous drainage.
Hmm. And in case a surgery is considered maybe later,
Exactly.
surgeon
But
will
that the
probably
reason to
want
get is just mainly for anatomy.
it. Hmm.
So we
Wonderful.
get it in every patient before adrenal vein sampling, just not to have any surprises.
Hmm. All
Okay,
right.
so as promised, this is how we interpret it. So this is again a real case. I made it pretty straightforward, but also wanted to highlight that in this case, as you can see, we check aldosterone concentration, right adrenal vein, left adrenal vein, and inferior vena cava, and we do our adrenal vein sampling with concentropin stimulation. Some centers are doing it without concentropin stimulation, or they actually are doing it with and without. So you have two sets of data. Also, if possible, we want to cannulate each adrenal vein simultaneously, but sometimes that's not feasible. So we do it consecutively. And typically our IR cannulates the right adrenal vein, because that's the one that is harder to get into. And then right after they do left. So it's important to know how your radiologist is doing the procedure because there are so many different protocols and also skills.
Mm-hmm.
At UT Southwestern, we do over 100 adrenal vein samplings per year, and we have not even a handful. We have basically two, maybe three maximum interventional radiologists who do these all the time. And
Mm-hmm.
that's very important because it's doesn't have a lot of complications, but it's a very nuanced and technical procedure given how small adrenal veins are. So then we also measure cortisol. Again, this is after concentropin or with concentropin stimulation, in this case infusion, and we then check aldosterone to cortisol ratio in each vein. And then what we are looking at is a couple of components. First, you can see that in this case, the left aldosterone to renin concentration is significantly higher than right, even though the patient has a nodule on the right, and you can see that dominant to non-dominant aldosterone to cortisol concentration is 13.6. So definitely indicating that aldosterone is coming from left side. Also, if you look at the aldosterone to cortisol concentration on the right adrenal vein, which is 0.43, it's actually less than that in adrenal vein sampling, which is 0.64. So this is a kind of a doubly confirmed left-sided aldosterone, and the right adrenal is actually suppressed compared to IVC. And again, we don't have to see the contralateral suppression, but it certainly helps to see it. Also, say in this case, if we did not get into the right adrenal vein, say they just could not get into it, didn't cannulate it properly, but you have this information with right aldo to cortisol suppressed compared to IVC. With this partial data, you can still send the patient for left adrenalectomy because you can argue that, well, there is PA, the right side is completely suppressed compared to IVC, so it's certainly reasonable to send that patient for left adrenalectomy and use that partial data for interpretation. So the first step is, are catheters in correct position? So I don't even look at aldosterone before I assess this portion. And that's when we are looking at cortisol in adrenal veins compared to inferior vena cava. And that ratio, I use cutoff at least 5.
Mm-hmm.
Ideally, it should be very, very obvious, but some centers use 4. I trained with 5. So ultimately, we want that ratio to be very robust. So first, we confirm cannulation. The next thing, that's when we are looking at aldosterone production. Is it lateralizing? So that's when we are using dominant to non-dominant A to C ratio. And if it's 4 or more, then we say yes. Obviously, this is a slam dunk case. If it's between 1 and 3, we say this is bilateral. Between 3 and 4, it's a gray zone. You can use clinical decision making to see if that patient would be somebody you want to send for surgery or not. And then in this particular case, as I mentioned, adrenal vein sampling lateralized to the left adrenal vein. Additionally, right adrenal A to C ratio is suppressed compared to inferior vena cava. So the patient underwent left adrenalectomy and postoperatively potassium supplements were stopped. ACE inhibitor was held and the blood pressure improved. We routinely check potassium levels weekly for at least 4 weeks in a row to make sure that there's no rebound hyperkalemia and slowly titrate their medications down. In this particular case, actually, with right adrenal vein being suppressed, you
Mm-hmm.
expect kind of a hyperkalemia, and the patient had potassium go up as high as 6.1. We treated him with a little bit of fludrocortisone just to bring down that potassium. We can use also sometimes hydrochlorothiazide if needed, if it's an option, just to bring potassium down and then periodically check it. And after 6 weeks, things stabilized. Blood pressure can take at least 3 to 6 months to get to new baseline. So we might still use medications, but monitor and adjust blood pressure medications as blood pressure allows. Okay,
Mhm.
let's move on to case
Oh,
three.
yes. Our third case is a 56-year-old man with hypertension, which is controlled with spironolactone 50 milligram daily and amlodipine 10 milligram daily. His screening for PA was performed, which showed aldo level of 21 with suppressed renin and hypokalemia, mild hypokalemia. So in this case, Oksana, can these results be interpreted while on these blood pressure meds? I know you briefly mentioned we discussed, but if you could give us more information on this.
Yeah, so when we see this medication list, we immediately want to jump to, oh, we need to wash out spironolactone, and then we do the testing. But as I mentioned and alluded to earlier, you can see that plasma renin activity is completely undetectable. What
Mhm.
this means is that spironolactone is not distorting these results, and we can go ahead and interpret all of the tests without the need to adjust any medications, including spironolactone. So my answer is yes, these results are interpretable, and no blood pressure medication, including spironolactone, will cause false positive testing for primary aldosteronism.
Mhm.
So, but if, say, the patient's aldosterone concentration was elevated, like 21, but renin is not suppressed, say, what if renin is 10? Then you cannot interpret those tests. You have to
Mhm.
hold blood pressure medications or switch to other medications like alpha blockers or certain calcium channel blockers, and then repeat the testing, say, in 4 to 6 weeks. Eplerenone washes out quicker, so you can even do testing, say, in a couple of weeks. Spironolactone can take a little bit longer depending on the dose, so you might want to wait 4 to 6 weeks. But don't just peel that off. Make sure that the patient is on medications that control blood pressure but do not interfere with biochemical testing.
Yes,
So,
I think this was one of the most intimidating things for, even endocrinologists to stop the
mhm,
medications. How long, do we need to
yeah.
stop? So the newer guidelines recommending universal screening on medication is really hopefully going to make a big impact on catching these patients. So
Yeah, we overcomplicated it, and endocrinologists love complicated things and algorithm, and we like to think, um,
numbers,
yeah,
yes.
numbers and ratios, but this was way too complicated, and we learned from that experience by noting that basically barely 2% of people who should have been tested were actually tested for PA. That's
Wow.
very poor statistics for patients who would benefit from therapy. But ultimately, these medications, like beta blockers, can suppress renin, but can also suppress aldosterone. So that's when it can throw off the ratio, but please note that aldosterone will also go down. So you're not seeing aldosterone is high, renin is low in this case. No, both will be down. For ACE inhibitors or ARBs, again, renin can go up, and that can also suppress aldosterone. Potassium-sparing diuretics like spironolactone, for example, can cause renin to go up significantly, and with that, of course, aldosterone will go up too proportionally. And then also potassium wasting diuretics can increase renin basically through dehydration. And then also with that, aldosterone can go up a little bit or stay the same. And then also for calcium channel blockers, they can increase renin and suppress aldosterone. So that's just important to know this interaction with different antihypertensives, mainly when you're suspecting false positive or false negative results. But if your results are straightforward, it does not matter what regimen they're on. So, and here is why. So this is, say, a patient who has adrenal adenoma,
Mhm.
and the adenoma is on the right side, and the renin is suppressed again, regardless of the underlying blood pressure medication. So you can see that aldosterone is suppressed. I'm sorry, renin is suppressed in both adrenal glands, and aldosterone is only produced by the adenoma side. Now, if there is an adenoma, but renin is not suppressed, you can see renin is going up in both adrenal glands. And that's because they're, for example, on hydrochlorothiazide. that can also raise aldosterone. Renin is high, so aldosterone can be elevated not just from the adenoma, but also from the rest of the adrenal gland and also contralateral. So that's when the test potentially can show bilateral disease or maybe even gray zone, when in reality it was the medication causing interference with raising renin. So that's why I'm highlighting the importance of checking renin before adrenal vein sampling, just to make sure you don't have this situation when it looks like it's bilateral, but that's because of the medications.
Mhm. All
Okay.
right, let's move on to our next case. A 65-year-old man with long-standing hypertension on 3 drug therapy with variable blood pressure control, and screening was performed. Aldo is now a little lowish, 7, with suppressed renin and normal potassium, low normal potassium again, 3.9. Now, this is more subtle. The question is, Dr. Hamidi, what would you do next?
Yeah, so this is generally when traditionally or historically we would look at this and say there's no PA, right? And even the
Yes,
guidelines say there's no PA, but you can see
10
that
was
this,
the number the guidelines went by. Yeah.
yeah, 10 or 7.5, depending on the assay.
LCMS.
At UT Southwestern, we used to use mass spectrometry. Now we switched to ELISA, just so that we can do it in-house with quicker turnaround. So it's just important to know which lab you're dealing with. Quest usually uses mass
Math.
spectrometry for the most part. Mayo Clinic Lab uses mass spectrometry as well.
Mhm.
But ultimately, what you're seeing is this concept of low renin hypertension. There's no doubt about it. The patient has 3 drugs, blood pressure is variable control. The question is, are we dealing with a false negative result? Or maybe say, let's assume that there's no medication interference and this is just what we get. So, what we discussed the following options. So, we are dealing with a mild case of PA, and again, maybe the labs are just not sensitive enough to catch it, but maybe just a very mild case. But again, it's a low renin hypertension state. If patient is interested in possibility of surgery, this is when we discussed, again, these are options, discuss 24-hour urine aldosterone. Basically, we're doing aldosterone suppression test. If aldosterone suppression test in this case is elevated, that's when we would say most like there's a high chance that this will be unilateral. So let's get your CT scan, send you for adrenal vein sampling because we are trying to see if surgery is an option. Or we discuss these are mild labs, most likely there's not going to be a high yield for adrenal vein sampling. Then we can talk about empiric treatment with a mineralocorticoid receptor antagonist like spironolactone or plerixafor. Again, 65-year-old, 3 blood pressure medications, labile blood pressure control. So certainly we can empirically treat in this particular situation, but discussing all these options.
I was going
So,
to ask, I feel like, looking at the current conjuncture and how things are moving forward, I feel like we're moving towards more low renin hypertension and eventually, maybe considering this as a spectrum. Um,
mhm. Yeah.
how do you feel about
Just
that?
like absolutely, it's a continuum. And we know that higher aldosterone, typically more severe diseases. And
Hmm.
if it's a younger patient, typically it's more likely to be unilateral disease. But
Hmm.
those are all generalizations, so we still have to evaluate the patient individually. But
Hmm.
this is to highlight that this concept of low renin hypertension, some would say if your renin is completely suppressed, then the only way for aldosterone to be made is autonomously. So it basically is just a milder version of PA.
Hmm.
Even though it's mild, I want to emphasize that it still has major consequences. And we typically see the following kind of 3 main points I wanted to make. High PA prevalence is typically driven by bilateral disease with somatic mutations that result in milder phenotype. So Some PA experts would say, if I look at your adrenal glands and see these micronodules, I can tell you how old you are. So it's like a tree that has rings. We can tell how old the tree is. For
Mhm.
us, it's just how many of these micronodules with aldosterone production we see on the adrenal gland, just basically normal aging pattern that we can more likely to cause with these somatic mutations, milder phenotype. 11% of normotensive individuals have biochemical evidence of PA. And this certainly, although we might not need to do anything at that moment, the patient is normotensive, but that patient has increased risk for future hypertension.
Is
We
it more common in individuals with like high salt intake, Dr. Hamidi, by any chance?
we know that there are definitely a lot of environmental aging factors that contributed, and we think that our dietary choices certainly contribute to that increased risk of somatic mutations over time causing micronodules. But there are
I'm
definitely
assessing my own personal risk here.
yeah, definitely. There are certainly mutations, germline mutations that can lead to adenomas, and typically those would be starting at the younger age. But the later onset usually signifies somatic mutations leading to
Mhm.
PA milder cases, and typically bilateral. Even with mild PA phenotype, it's still independently associated with worse cardiovascular and renal outcomes. So that's the reason to keep in mind that even though it's mild, it still has major consequences, should not be ignored.
And a
We,
question, do you
yeah, we can
retest?
certainly, I would definitely treat that patient with mineralocorticoid receptor antagonist. And I do offer rechecking those levels periodically, say maybe at 1 year, or if I see blood pressure is worsening, to recheck it at that point. But the patient will be treated at least. Say if it's still a year, you're thinking about it, waiting, you are treating that patient, so you're mitigating their cardiovascular risks. That's a very good question. So basically, this is again from the guideline. We are, when we diagnose PA, the next step is to assess the surgical candidacy. Is this individual wanting surgery? Are they going to be potentially a good surgical candidate? If it's a no, then we don't need to do any further assessments. We treat them with mineralocorticoid receptor antagonist. But if the patient has probability of lateralizing, okay, how do we know? We don't really know, but ultimately looking at aldosterone, blood pressure, potassium, aldosterone to renin concentration, age, so all of these factors, are we likely to lateralize? And when the probability of lateralizing is low, like in this patient, 65, aldosterone
Mhm.
is 7, renin is undetectable, no hypokalemia. So, for example, if those features are present, we say low probability for lateralizing. Let's try MRA. Again, we are not ignoring this patient, we are still treating, but we don't want to subject them for this procedure that is most likely to be bilateral. Or say if you don't even have access to it, then we say, not worth traveling out of state for this. Let's just treat you empirically. If the probability is intermediate to lateralize PA, that's when we discuss several options. We can talk about empiric trial of MRA, or we can talk about proceeding with aldosterone suppression test, and then think about doing adrenal vein sampling at that point. Oops, sorry. And then again, following the same algorithms. Now, if your probability is high for lateralizing, say the patient has hypokalemia, very low renin, very high aldosterone, after correcting hypokalemia, we want to proceed with CT scan, and then think about, of course, adrenal vein sampling, because the surgery could be curative. And then, so what about surgery versus medication? Can we just put everyone on medication? It's cheap, it's effective. So this was a meta-analysis of 17 studies looking at adrenalectomy versus MRA therapy. So it's about half and half. So you can see the average follow-up in this systematic review meta-analysis was 23 months. So it's not long, but it's also, I would say, pretty good. And half of the patients were on surgical groups and half on medical therapy. And looking at both, we still see that adrenalectomy led to greater reduction in the left ventricular mass compared to medical therapy. That was the primary outcome, but also greater reduction in left ventricular hypertrophy with modest improvement in left ventricular ejection fraction. So MRA therapy led to 19% reduction in left ventricular hypertrophy risk. And this effect was unfortunately attenuated by high sodium intake. So this is to emphasize that even when the patients are on MRA, it's critical to talk about low sodium diet because they can just like you cannot outrun your spoon, you cannot outrun this in this case sodium intake. So it's still critical to follow a low sodium diet. Shorter hypertension duration led to greater mass improvement. So this is after adrenalectomy, again, emphasizing that we should test for this sooner so that we can intervene earlier and lead to improved outcomes. And then we do look at the renin as a biomarker to help us guide medical therapy. So what I wanted to show here is that this was a cohort study out of Brigham and Mass General, and they looked at over 600 patients that were on medical therapy, mineralocorticoid receptor antagonist. They also found a lot of age-matched controls with essential hypertension. So they have a great database for these cases. And they looked at incidence of cardiovascular events, so including MI, revascularization, heart failure admission, and stroke. And they found a twofold higher risk in PA for these primary outcomes versus essential hypertension, unless their renin was greater than 1, meaning that their medical therapy with MRA was optimized to the point that renin was no longer suppressed. In that case, you see that if we just put them on MRA, but renin is still suppressed, then their risks are still twofold higher compared to patients with essential hypertension. But if we bring that renin down, I should say, we bring that renin up, unsuppress it, and it's at least 1 or more, then the risk is equivalent to those with essential hypertension. So what this means is that we monitor renin as part of the medical therapy, and we are trying to keep it unsuppressed, and not just blood pressure control, but also looking at renin and potassium, trying to keep it in the upper end of the normal range to optimize their medical therapy and minimize their cardiovascular risks. So hopefully this is clear that the reason why we titrate MRA is to achieve rise in renin for additional beneficial outcomes.
All right, so our patient actually was started on spironolactone 50 milligram daily, which was added to his 3-drug therapy in his last visit 3 months ago. Blood pressure is now well controlled. It was previously uncontrolled. It's now well controlled, but he complains of gynecomastia. And here are his results. Aldosterone 26, renin 4.5, unsuppressed, but the potassium is a little on the higher end, 4.7. So, Dr. Hamidi, what would you do next?
Yeah, so I wanted to share different therapies. So spironolactone is our most effective therapy, MRA therapy for PA, but it does have high incidence of gynecomastia, which is dose dependent. So you can see the higher the dose, the higher the chance for gynecomastia. Say in patients who need 100, 1 out of 3 will have gynecomastia. So that's the limiting factor. Still, we oftentimes discuss spironolactone with our male patients, and some of them don't even want to try it. But ultimately, it's dose dependent. So if these adverse events arise, then we talk about switching them to eplerenone. Eplerenone, common mistake is that I see it's given only once a day. It has a short half-life, maybe 3 to 6 hours. It must be given at least twice daily. So if the patient is intolerant to spironolactone 50, then basically eplerenone is twice, I should say spironolactone is twice more potent. So if you're trying to convert to eplerenone, then just give them 50, but BID twice a day. Then goals of therapy are not entirely straightforward, but usually we try to get blood pressure under control, ideally with optimizing their MRAs. And we try to keep potassium in the upper end of normal range. And renin, kind of the sweet spot is between 1 and 2, so we don't want to keep it too high. Sometimes there are other medications that can also cause renin elevation, but ultimately, if you're just thinking about the sweet spot, I wanted to show the information about this between 1 and 2. So you see that's the U-shaped curve, and at the bottom is the lowest cardiovascular risk, so kind of optimal spot between 1 and 2. So we are just trying not to keep it suppressed, but also we don't want renin necessarily to be high. Again, this is only in context of primary aldosteronism, so it does not have anything to do with people who are on ACE inhibitors and ARBs for other reasons and do not have PA. So again, spironolactone, long half-life, 12 hours, but is limited by hyperkalemia, gynecomastia, menstrual irregularities, erectile dysfunction. Eplerenone, shorter half-life, so must be given at least twice a day. And esazerenone, it has the longest half-life, so obviously doesn't have any effect on androgens, but can lead to hyperkalemia. And it has the longest half-life out of all of these three. And this is data on esazerenone leading to improved systolic and diastolic blood pressure by a lot. I also just wanted to briefly talk about aldosterone synthase inhibitors or ASIs. These particular therapies target aldosterone synthase at the level of the adrenal gland. So that's the last step of aldosterone synthesis or CYP11B2 enzyme. So by selectively blocking it, it leads to reduced aldosterone levels and basically it treats the root cause of disease. And ASIs may find a major role for medical therapy for PA, but also even hypertension without PA in the near future. We have studies ongoing, but they are not FDA approved in any country right now. So this was a phase 2 study on one of the ASIs, dexfadrostat, just again, proof of concept. And you see this phenomenal reduction in aldosterone to renin ratio and also a decrease in systolic blood pressure by 10 points over just 8 weeks. So that's now this is phase 2 data on baxdrostat. Again, only 15 patients, and you see that, I mean, this is remarkable. Mean systolic blood pressure decreased by 20, down by 25 milligram per mercury, milliliter per mm, millimeter mercury.
Millimeter.
Potassium corrected in all participants who had low potassium, and then the aldosterone to renin ratio decreased by 97%. So basically, this study shows that PA was obliterated. And that's, again, phase 2, 15 patients. So we have phase 3 studies ongoing. Just very, very briefly, future directions for PA. We are looking more into subtyping PA by looking at nuclear imaging that potentially could obviate the need for adrenal vein sampling. So this is gallium-68 pentixafor scan has promising results. Then also we are looking at better medications that have better affinity, more selective mineralocorticoid receptor antagonists like esazerenone that I mentioned, but also now looking at the potential role for aldosterone synthase inhibitors, and one of them would be baxdrostat. And
All
then we are
right.
also investigating novel ablative procedures that basically use radio frequency ablation to to target aldosterone producing adenomas. As you can imagine, these are not effective for micronodular disease, but for adenomas, especially in certain ethnic populations, that could be effective. We're looking at novel approach of using these ablative techniques by combining information from emerging nuclear imaging modalities and looking at endoscopic ultrasound guided radiofrequency ablation. Specifically, it's helpful for left-sided aldosterone producing adenomas because of their proximity to stomach.
Mm-hmm.
So, just key takeaways, and thanks for everyone patience. But the key takeaways from this study is that, for this presentation, is that please keep a screening broad. All patients with hypertension, not just those with resistant hypertension or hypokalemia. As I hopefully shown you that primary aldosteronism is common and harmful. It causes cardiovascular and renal injury, even with controlled blood pressure. Confirmatory diagnosis, start with baseline aldosterone and renin. If positive, you consider aldosterone suppression test in some cases, but then you can proceed with CT scan and adrenal vein sampling for subtyping. I'm sorry, for lateralization. Lastly, treat blood pressure control, but beyond it, important too. So in people who are on MRA, or if they have adrenalectomy, we are trying to achieve reduced end organ damage. Monitor therapy, so aim for renin to be greater than 1 for optimal risk reduction. If it's a surgical case, then usually it takes at least 3 months for renin to unsuppress. So just don't be alarmed if your post-op renin is still low. And then future options, looking at high affinity MRAs or aldosterone synthase inhibitors. So this
Thank you.
concludes our cases and the presentation. And
Thank
again,
you
I
so
wanted
much,
to
Dr.
say,
Hamidi, for walking us through these cases. This was incredibly insightful and practical. We have a couple of minutes, if you don't mind. Someone asked in the chat, do you see remission of PA in elderly?
and as far as after surgery,
Um, I think after surgery, no, no,
so
okay.
a remission of PA means different things. We are looking PAMO criteria. So by looking at remission, it could be a couple of factors. We could be looking at their potassium. Usually the remission is virtually 100% the day after
Mhm.
surgery. We are looking at also aldosterone and renin. So absolutely, if it's a unilateral disease, their aldosterone plummets after surgery. Renin typically stays suppressed the first couple of months, but then by month 3, usually we check it. So that usually um, becomes unsuppressed at that point, assuming they're following low salt diet. And then the blood pressure control, we usually do not promise normalization of blood pressure, but absolutely we see reduction in blood pressure medications and improved control, even if they still need to stay on antihypertensives. Just that's expected. The longer
Mhm.
hypertension, standing hypertension, kind of the more likely chance that they will need to be on medications. But I can tell you that their blood pressure is significantly different, even if they need some antihypertensives.
All right. And Dr. Hamidi, I was wondering, since we are also seeing patients with diabetes, for someone who has CKD and type 2 diabetes, might be on, finerenone, these non-steroidal, MRAs. Do you think that can replace steroidal MRAs? Can
Yeah,
we
so the
consider
limitation
keeping
is
them on
it potentially could be beneficial, but we don't really have any good data on
data?
PA. And we have some data, I should say, but and it looks promising, but the problem is it's not FDA approved unless the patient has diabetes and CKD or heart
Mhm.
failure in CKD. Those medications could be cost prohibitive. So
Oh.
even though they technically could be beneficial, it's just really hard to get coverage for them.
And my last question is, when do you screen for familial cases? Like, when do you send patients to genetic testing? Because I have never done that myself. So,
Yeah, so actually, this is typically in a situation when the patient, we always ask, does something like this run in your family? Do you see early onset cardiovascular disease or especially end-stage renal disease? And these mutations are usually autosomal dominant. So something like that declares in the family. And actually, I don't test everyone routinely,
Mhm.
but I have tested some patients that express that family history, and we have genetic testing that can help diagnose the genetic underlying disease.
Are
Just
those available through commercial labs?
Yes, they
Can we
are.
send it
Yeah, and they are
easily?
generally well covered too, from my
Mm,
experience. Again, I don't do a lot of them, but I have
mm.
done, and our cancer genetics, but also even just non-cancer genetics team can provide guidance, and they've been super, super helpful to test that patient, but also help interpret those results.
Wonderful. Thank you so much, Dr. Hamidi. And thank you all for joining our first Endo Expert Up case discussion session. Have a good rest of your day.